My name is Jessica Gorham, and I'm the Regional Emergency GBV Advisor working on behalf of the Gender-Based Violence Area of Responsibility here in East and Southern Africa. But for the purpose of today's event, I am also the chair of the Regional GBV Working Group for East and Southern Africa. I'm really happy to see so many of you joining us today for our second installation of our three-part series focusing on mental health and psychosocial support services. Similar to our previous events, we do have simultaneous interpretation available. Please do read the instructions on the screen to access Portuguese, French, or Arabic. I will wait just 1 or 2 seconds for you to be able to do that. Also, please note that all of you should be on mute so that we don't disrupt our presenter. And please do keep your cameras off. We have people dialing in from lots of different places around the world with varying internet strengths. And so we want to give them the best opportunity to be able to listen as well. So please keep your cameras off and yourselves muted throughout the webinar. If you have any questions, please do write them in the chat. Myself and colleagues from MSF will be monitoring the chat throughout, and we will try to, I thought I was going to sneeze there. We will try to answer your excuse me. I also have a cold. We will try to answer your questions in real time. So I'm happy to also have Rayon, who was our presenter yesterday. Thank you. Who will be helping me monitor the chat today. And similar to previous learning events, we will be answering questions in real time. Finally, we will not be sending out the PowerPoint presentation. You can access a recording of this webinar on our YouTube channel. All you need to go is onto YouTube, search engine, put GBV AOR, and you will find this webinar, a recording of it, on our YouTube channel. So just to note, we will not be sending out the PowerPoint presentation individually, but you can access the webinar in its entirety, which includes the PowerPoint presentation, on our YouTube channel. Next slide, please, Shiva. Thank you. As I mentioned, this is a three-part series that we are focusing on mental health and psychosocial support. And this is the last event for our 16 Days of Activism campaign. We hope you have been along with us on this journey. We have been sending out videos of our adolescent human rights defenders, and we've also had various webinars throughout our campaign for the 16 Days of Activism. As we noted, yesterday was Human Rights Day, and I want to reiterate this again, that healthcare is a human right, and mental health is a part of that right. And so we want to make sure that everybody has a clear understanding of what we mean by mental health and psychosocial support, which is why I'm really happy today to introduce today's presenter, Ana Marquez, who is the Regional Mental Health Advisor at MSF Barcelona. And she will be taking us through a spectrum of psychosocial support interventions for survivors of sexual violence. So welcome, Ana. We're really pleased to have you here today. And now I'll turn it over to you.
Hello, everyone. I'm Ana Marques, Global Mental Health Advisor for OCBA. It's actually a pleasure to be with you here today. yesterday I had my colleague Hayan speaking about the more theoretical framework on sexual violence, and today I'm going to move to response. Okay, and tomorrow you'll have more of an example of what our team in Palestine is also doing. In this response, I'm going to basically to frame what any professional that has been trained and that can work on that can be supervised can provide the kind of psychosocial care that he or she can provide, even if he or she is not a mental health professional. And then I'm going to speak more about what we as mental health teams in MSF, what is our package of care. Can you already see my presentation in presentation mode?
Yes, we can see it
Okay.
well.
Okay, perfect. So let's start it. And then I cannot see the chat. So whenever I ask for questions, I will ask Ryan or you to help me to say one of the some
Mhm.
of the issues that are coming up in the chat. Is that okay,
It
Jess?
is. Yep.
Okay,
And
thank you.
Anna, if you could just hide the stop sharing sign, there's an app just at the bottom of your
Yeah,
screen. Yeah,
yeah,
there we go. Perfect.
absolutely perfect. So let's go ahead. So actually, we start exactly with the question. So, what are the main principles to ensure that we are responding properly to survivors of sexual violence? Please write in the chat in 30 seconds, 1 minute, your main ideas. So, Jess, Ryan, what is coming up in the chat?
We
We
have
can
guiding principles.
Mm-hmm.
confidentiality,
Okay, very important.
again, confidentiality,
Okay.
respect and dignity, consent,
Mm-hmm.
respect,
Mm-hmm. Okay, so
non-discrimination, safety. Yes.
okay. So I think you're already nailing it. You have a lot of what I'm going to say after this. So, what are the main principles? First of all, we have to ensure all the survivor centered principles that you are saying. Having a safe space, and having a safe space is not just about the space, the physical space itself, but creating a psychological space where people feel that it's safe, private, confidential. So obviously, as you were saying, ensuring confidentiality, privacy is absolutely fundamental. The other idea when we actually are trying to respond to survivors of sexual violence is to be able to properly identify them. If we don't identify, we cannot actually respond to survivors of sexual violence. So this is another absolutely key principle in responding to survivors of sexual violence. Then, obviously, ensuring that we are using a proper communication. As you were saying, that we are respectful, that we are empathetic, that we are not discriminatory, that we are not judgmental when speaking with people. This is absolutely essential. The other idea is whenever we have someone that is a survivor of sexual violence, we should be able to provide basic psychosocial care. So we should be able to communicate with the person in a way that actually protects her mental well being and actually promotes her mental functionality. The other idea is even if someone was exposed to violence once or more, it doesn't mean that there is no risk of being further exposed to sexual violence. And it's really important that when we interact with survivors of sexual violence, that we are able to do a safety plan so that if another risky situation comes up, the person is more equipped to deal with that situation. And finally, the idea that survivors of sexual violence have different and multidimensional needs, and we would need, there is not one organization that will be able to respond to all these needs. So we need to map, we need to understand who is in the catchment area where we are working so that we can refer the person for more comprehensive and holistic care. Obviously, when we speak about referrals, we also have to speak about consent, no informed consent. We cannot share information, we cannot share any information about the survivor without the consent of him or her. So after this, saying this, how do we actually prepare a response to survivors of sexual violence? And we have mainly three initial dimensions that we need to work on. One is to identify and assess the services that are exactly in our catchment area. Who is providing medical care? Who is providing mental health care? Who is providing social, legal services, financial protection? So we need to understand all of these. We need to map all these actors and actually to develop a referral system that is effective, that is solid, and that it's well functioning. Then, as we spoke before, the idea of having a private space, a space that actually ensures confidentiality. But it's also very important when you are planning a space that it's not also itself discriminatory, because for example, I can see sometimes our teams in the field, they identify a place that they find it's really nice because it's confidential, it's very private, but then it's just a place for sexual violence, very divided from the other services, and it becomes the sexual violence place. So whenever you enter there, it means that you had been experiencing sexual violence. So it needs to be private, confidential, but also in a way that itself does not stigmatize or does not identify someone that has went through sexual violence. Finally, we need to have our staff trained on identifying and responding and having at least the first line, the basic response in terms of provision of basic care to survivors of sexual violence. This training should be a training that considers obviously gender, age, the context, sexual orientation, all of that. So next question, and I will need again the help of Jess and Hayan. What are some key signs of possible SV? And for the ones who were here yesterday, Hayan already gave you a lot of information on this. So what is coming up in the chat, ladies?
Yes, now it's physical injuries because many still are saying hello and where are they from?
Okay.
Withdrawal,
Uh-huh.
bruises, isolation.
Very well.
They are repeating the same wounds.
Mm-hmm.
Distress, threats of suicide, fear and anxiety, trauma.
Mm-hmm.
Issues with the translation. Not really.
Okay.
Sadness, self-esteem, trauma.
Okay. Okay.
Withdrawal.
Okay. So I think you basically summarized a lot of the signs that we have, and let's say that we have obviously signs in three big areas. We would have more physical signs, we would have more psychological signs, and we would have more behavioral signs. So in general, in terms of physical signs, we have to consider, obviously, as you were saying, bruises, injuries, including in the genitals. And for us, as a medical organization, this is something that sometimes we have access. It's also not uncommon that we will find people that have sexually transmitted diseases. Or people that come to us with unwanted pregnancies, or that tried to have an abortion in a traditional in the community and somehow it didn't go well, and they come to us because there is a big emergency or something, and obviously they need further help. In terms of psychological and behavioral clues, obviously people that have some signs of depression or anxiety, that are very sad, irritable, that may be very angry. Some of them have organic, so body complaints that the doctors cannot find actually a cause for that. Some of them have engaged in alcohol abuse or other substances abuse. And in some cases, we will see also some signs of a traumatic experience. So as Hayan was saying yesterday, hypervigilance or hyperarousal, having very disturbing nightmares, or having flashbacks. Flashbacks is basically when the person is here, but suddenly she feels she or he feels back in the situation, in the sexual violence situation, being attacked and being in a very disturbing situation. In more complex cases, we might see, as you were saying, people with suicidal thoughts or even suicidal attempts. As also Ryan reinforced yesterday, we have to have special attention to children. Their reactions, they have some in common with adults, but they also have very specific responses. So from a physical point of view, obviously the bruises and the injuries are there. Eventually we will see kids with headaches, or we will see teenagers that also come for pregnancies or come for abortions that were not completed and need extra help. From the psychological signs, we can see children that are sad, that are very scared, that are feeling very hopeless. We can even see in some cases some suicidal attempts. Behaviorally speaking, it's not uncommon to see a child that is isolating, that is withdrawing from his or her social activities, that does not want to go to school, that does not want to go out with his or her friends, or play outside with his friends. It's also common in teenagers that we will see teenagers that engage in very risky behaviors like binge drinking or driving in motorcycles at a very fast pace. And also, we can see over sexualized behavior on some of these children. For example, I just came from Mozambique, and we have a child of 2 years old that we suspect of some form of sexual violence. That she is basically role playing physically in her movements, sexual intercourse with toys or with pillows, and we are trying to understand exactly what happened to that child. In men, why should we pay special attention to men? Usually because men are overlooked, no? The other day I was revising a document from one of our projects, and we always have the referral pathway for SV in our mental health strategies, and it was a pathway just for women. And I was like, guys, come on, we have to look at men, even if we are identifying less, or if there are less men that are subject to sexual violence in the community. It's really important to still be prepared and ready to identify men that have been under sexual violence. And it's super important to consider that in specific contexts, for example, in detention, in prisons, it becomes more frequent. In armed conflicts, especially when men are subject to some form of torture, sexual violence is also pretty much used. It can actually be a weapon of war, and men are many times subject to it. In terms of physical signs, we will see the injuries, the bruises, sometimes some difficulties in urinating or defecating, and erectile dysfunction, for example, is something that it's not that can happen. Again, just coming from Mozambique, in one of our projects, we have a huge cohort of men complaining about erectile dysfunction. In that case, we are not sure if it's sexual violence, but we feel that it's very much related with the experience of violence in the area. In terms of psychological symptoms, we can see men very much irritated, angry, obviously sometimes also sad and anxious. At a more behavioral level, it's not uncommon to see men that engage on unsafe sexual activity by having sexual intercourse with sex workers or with unprotected sex. It is also not uncommon to see, and this happens with men and also with children. I didn't speak before about having fights with peers in their usual activities. It's also common amongst men that sometimes it's not the man himself or herself, or the man himself asking for help. It's sometimes the wife, the partner, sorry, that is identifying that something is wrong and is requesting help. It's also important when we consider gender that we have our staff, we have a multi-gender staff team. It's common that people think that if it's a man, he should be seen by a man, but our experience is not that. In some cases, men would prefer to be seen by a man because they are speaking by another man because they are speaking about something that is very intimate and they might be shy speaking with a woman. But it's also true that some men would prefer to be seen by a woman because they feel very ashamed of what happened, and they feel that especially when there is sexual violence by another man, that they might be seen by the other man as gay, as homosexual, and this might have implications. So what is our protocol is to give people the choice to choose the gender of the people who are going to help them and who are going to provide care for them. So one more question. Well, actually, I have more questions, but one at a time. We already spoke about signs that are observable, that we have to pay attention, but obviously they do not allow us to say that someone had experienced sexual violence. We have to go a bit further in our identification. Should we ask someone about if he or she was raped, or if she or if he or she was subject to other form of sexual violence? And should we ask everyone, or should we just ask to the ones that we saw potential signs of sexual violence? What is your opinion? And ladies, I will request again your help.
Actually, for now, they are asking. So, question is from Peter. Peter, just to let you know that Anna is coming to this in a later stage. Exactly the answer for your question.
Okay.
What do you ask if I know someone has been? So some people are saying ask everyone. And then universal screening is not allowed. We can only ask if we see any signs. Oui, les documents médicaux légal. So maybe when asking for medical and legal documents. Also, others are saying screening to all. We should not ask. In my opinion, achieving survivor-centered case management, which we promote GBV case management, may be challenging if we rely on GBV case identification due to the sensitivity and risk level of these issues. In some contexts, they go with GBV screening tools, which could inform the next line of action.
So
not ask, but observe. Yes, sorry.
Okay, thank you. So what is MSF protocol, and actually also WHO protocol, is to do selective identification. We don't do generalized questions about sexual violence, about the experience on sexual violence, but it's important that whenever we see factors and signs of potential risk, that we ask the potential survivor if this happened to him or to her. So not to everyone, not has overall question that should be always asked to everyone that we encounter in our services, but just to the ones that provide that we see some signs of eventual sexual violence. So how do we actually ask people about sexual violence in a way that is protective of their well-being and will give also a chance for us to proceed on providing care to people? The first step is obviously to introduce yourself, to explain who you are, which organization do you belong, which are the values and the mission of your organization. So me, for example, I would say I'm Ana Marques. I'm a psychologist. I'm a psychologist working for MSF. MSF is a medical humanitarian organization. And it's a medical organization that provides medical humanitarian care based on neutrality, impartiality, and I would continue introducing MSF. Then it's important that before we ask a direct question about sexual violence, that we somehow warm up and we provide some context and we give some form of preparation to the person that we are going to ask about such a difficult event. So we can say, look, I can see we are in a very difficult context here. Here, the community have been subject to conflict, armed conflict, or earthquake, or a flood, whatever it happened, and this obviously has many consequences to the people's lives because they lost livelihood, they lost their jobs, or they lost their houses, or they had to flee. And this obviously has an outcome also, a very high distress for the person. It's normal that people feel there is someone with a micro on. I would ask to put it off. And it's normal that people feel some form of mental distress at this point. And I would like to speak with you a bit about that. Then we reinforce confidentiality, saying this obviously is a private conversation. It's just between you and me. And if, for example, I see that there are needs in the future needs of support from any of my colleagues inside the organization or others, I would not share any information without your consent. You'd have to consent first if I can do it and what kind of information I would be able to share. And finally, we'll land on the direct question on sexual violence. But it's important here that we make a very clear question, that we don't go to a gray area, or that we don't use terms that might indicate sexual violence, because we feel more comfortable with using lighter conversations and lighter words, because these lighter words can actually has an impact. People can misinterpret what we are saying, and we might not have a clear answer, or we might not. It might not be clear what the person is answering to us. So what we might say is, in this context, unfortunately, we have been seeing that there are a lot of women or men or children or people in general that have been subject to some form of sexual act against their will. This obviously is very difficult. It's not their fault. And it carries a very high distress in their lives. Did something like this happen to you? Were you forced at any point to engage in some form of sexual activity against your will? And we listen, no? And we listen carefully to what the person is saying. It's very important that when we are trying to identify a survivor of sexual violence amongst children, we are over careful. And we don't do it exactly as I was telling you, which is a protocol for adults. When we speak about children, instead of the general question about how is this context, what happened in this context, it's more important to speak about the context of where the child is being raised. So making general questions like, tell me more about your family, how many siblings do you have, how many females and how many males, who lives with you at home, with whom from home do you play, do you have friends outside home, do you go to school, what do you play when you are outside with your friends. So creating an atmosphere that will allow the child to feel more comfortable with us, because keep in mind that many times they never saw us before. So creating this trusting atmosphere is really important. After this, we try to go for a more specific question, but not as direct as we would do for an adult. So here we could ask something like, have you ever been touched in a way that you didn't feel very comfortable, or you felt somehow scared or confused? Has someone been bothering you? Is there something that someone did to you and asked you to keep it as a secret, but it's something that you don't feel comfortable? Is there something that someone did to you that it doesn't seem to feel right to you. And we again listen, and we give a lot of space for the child to speak. Keep also in mind that sometimes when we work with children, the verbal channel is not the only channel that we should use to identify sexual violence. And we should go beyond just these questions. It's important to ask the child and the caregiver that is with him or with her about what are the main activities of this child, the daily activities. When more or less he or she wakes up, when he or she goes to bed, when does he have his meals, how many hours does he sleep, does he go to school, does he play with friends, does he play with the family, what are his favorite activities. So we try more or less to understand the routine of that child. Then we go for more creative activities that will somehow link more to the emotional part of the brain, to the right part of the brain, and can be, for example, drawing. We can ask a child to do an open drawing, saying, draw whatever you want, whatever you feel like, just draw. Or we can be a bit more directive, and we can ask the child to do a drawing of his or her family, do a drawing of the happiest memory that can help us, for example, in the future to understand what coping mechanisms the child might have. Or, for example, drawing the safety circle. You'd have like a white paper with a circle, and you'd ask the child to put inside the circle the people that he or she feels comfortable with, that feels that he or she protects her or him, that is close, that she feels very well with, and outside people that they are scared or less comfortable, that feels that they don't protect them that much. And this is already a very good indicator of the network and the social interaction of the child. Another idea is to ask them to tell a story, and can be very open. You can ask them to use, for example, toys in the room, and to have a story with toys. You should have a lot of toys that they can represent, for example, the different people in their family, some neighbors, some friends. You should have humans, but you should also have animals, because sometimes the child reflects the story not on humans but on animals or other forms. So it's important to really have a very big collection of play toys and play materials, so that the child can really reflect what is his life in this play. And you can also do other creative or recreative activities like collage, or like other activities that will not just help disclosure, but will for sure help to develop this trusting relationship with the child. It is important that sometimes to keep in mind that sometimes the child will not speak right away. Why does this happen? We can have many different reasons. It can be because the child does not feel yet comfortable with the practitioner. It's a new environment, it's a new person, so and it's very sensitive topic, so the child might not feel comfortable yet. The child might not feel comfortable with the caregiver that is with him or her at that moment. The child might have been threatened. It's not uncommon that in sexual violence in children that we would see that the perpetrator would tell the child that if he or she tells something to someone about what happened, that something bad will happen to him or her, or to her or his family. Or the child might be afraid that the caregiver inside the home will not understand the situation and will punish him or her somehow. So what should we do when the child is not speaking? First of all is be patient and give it time, Give it time to build the relationship with the child. Sometimes it's not in the first conversation, but you'll need 2 or 3 conversations to reach to something that is more tangible with that child. Also consider that sometimes is important, can be relevant to ask for a different caregiver to come. And most of the times it's very useful also to have specific times with the two people. So having an initial conversation with the caregiver and the child, also asking the caregiver not to go into too much details, because sometimes this is the case and we should protect the child. And then having a moment just with the caregiver where the child goes with one of our colleagues, and swapping them, and then having just a moment just with the child. So one more question to keep you awake. When an incident happened recently, what is the first line treatment, the first line intervention that protects the psychosocial well-being of the person? And spoiler alert, we already spoke a bit about that yesterday. So Jess or Ryan, I would count on you to read me the answers.
We're here. So someone wrote lives, health.
Wrote what? Sorry?
Lives, health, rapport, medical care if there is any acute injuries, medical, PFA, first line support lives, safety, PEP, rapport, ensure the survivor is safe, medical care, psychosocial support, medical.
Okay. Keep in mind, as I was telling you, that I'm speaking about the first psychosocial intervention. As many of you are saying, if it's medical emergency, the first response should obviously be to refer to medical care, so that, for example, PEP kit is applied, or if there are, for example, emergencies or something, that there can be a rapid medical intervention. From a psychological point of view, as some of you also said, the first line intervention in a recent event is psychological first aid. And in psychological first aid, we have basically 3 stages. We call the 3 L's of psychological first aid: look, listen, and link. On the look is more on the, it tells us if someone, disclosed about sexual violence, it's important to look at the person and to really observe the person. Does this person look sad? Does this person look irritable? Does this person look restless? How is his or her hygiene? How is he or her taking care of herself? So really observe the person that we have in front of us. The second step of psychological first aid is to ask the person about his or her needs. So saying something like, I see you went through a very difficult event. I'm so sorry you went through that. You should not have gone through that. It's not your fault. Now I would like you to tell me if I can help you, how I can help you, and to listen. It's much more important to listen than actually to speak. The person will say what she needs at that point. It's normal that the need to refer or to connect the person to other services will come up. So then we have the third dimension, which is the linking with resources. But keeping always in mind that we don't link without the informed consent of the survivor. Keeping also in mind that in psychological first aid, we are not going to review the situation of sexual violence. We are not going to ask the person what happened to him or to her. We are not going to review, and this can actually create damage. The other idea is that in psychological first aid, we should not ask the person how she or he is feeling. We know that right after an event, the emotional debriefing, especially when it's not done by a mental health professional, can be dangerous. If the person wants to speak about how he or she feels, it's fine, but it's not us asking for that, okay? And If the event was not disclosed right after, the steps are not very different, but let's look at that. Keep in mind that many times we'll have people disclosing about sexual violence after several days, weeks, or even months or years. We have cases like that. So, what should we do when someone tells us that he or she has been subject to sexual violence? First of all, we validate and reassure. We validate the person saying something like, I'm very sorry this happened to you. This should not have happened. It's not your fault. And I'm very, I really feel that you're very courageous to be able to speak about such a difficult event. Keep in mind that you're not to blame about this. And once more, this is incredible that you had the courage to come to me and to speak about such a difficult situation. Then we move to the second stage, where we ensure the person that we are speaking in a safe space, that he or she can share with us whatever he or she feels like. And it's also a moment that, again, we ask about the person's needs. What do you need? How can I help? Tell me about your fears. Tell me about your worries at this point. And we try to identify the need for support. In the next stage, we are going to describe a bit the support available and to provide information about this support. And as in PFA, we are going to finally ask the consent of the survivor to provide the referrals to another colleague from the same organization or from another organization. So after the survivor discloses, we are sure what happened, and after we gave the very first line intervention, psychosocial care, what are the other interventions that not just mental health professionals, but also other professionals that can be from protection, from education, from medical care, from other areas can also provide to make sure that we are protecting the mental well-being of the survivor, and we are promoting a safe environment, and we are promoting that there is not an escalation of symptoms in the future. So again, we go for validate and reassure, and you're saying, but why again? We already did that. Because it's really important that we keep coming back to that we keep saying that it was not his or her fault, that these emotions are okay to feel, that he or she is not to blame for this, and that it was immensely courageous to be able to speak about this situation. The next step, when we want to provide some basic psychosocial intervention, and keep in mind that the psychosocial intervention can be provided right after the PFA or right after the first line, or can be in another conversation. You should ask the survivor if he or she wants to continue talking, or if he or she would prefer not to talk more or to talk in a second moment. So the next step is exactly to provide psychoeducation. What is the key word in psychoeducation is normalizing. How do we normalize? We say to people that whatever he or she is feeling, sad, angry, irritable, anxious, fearful, this is normal in that situation. It's absolutely normal. It's important that we don't one thing is normalizing, the other issue is generalizing. We don't generalize. So it's important to say this is normal in this situation, but not to say everyone feels like that in that situation, because this diminishes what the person is feeling. Then we explain that there are many other different emotions that might come and that they are also normal. And that usually these emotions will decrease with time, but in some cases, if they persist or if they get worse, we should ask for for mental health support. With children, we have to be more specific. Now we have to explain to the child and to the caregiver that many emotions are coming, that they can stay for days, weeks, months, and that they might change. Now might be sadness, but fear might come, irritability might come, and that they will also see behaviors like not going to school, socially withdrawing, fighting amongst their peers, and that usually they decrease, but it might not be the case in the future. And to address the caregivers themselves, saying that sometimes feeling shameful, humiliated because they were not protecting their child are normal reactions and normal emotions, and that at this point it's more important to really focus on the healing of the child. And it's really very crucial that we say that usually children overcome these situations and they can have in the future a total normal life. This is usually very calming for parents. Then we speak with the person after we give psychoeducation about the coping skills. So what the person used to do that was pleasant, that it was good, like drawing or reading a book or praying or going out with a friend or going for a walk, that we should try to engage with these activities or even try new activities. Then that a daily routine is really important, that they have a waking time and time to go to sleep, that they have regular meal times, that they try to engage in their regular activities like going to work or having house chores or going with a friend for a coffee. And finally, exactly, trying to tap on the social support. So who is there that can help? Who is there that can be of a great to alleviate the distress? And sometimes it's not about speaking about the event. I remember a conversation that I had recently with a friend that has been through a very big ordeal, and she was telling me, speak with me, but don't speak about what is happening to me. So it's really about tapping on social support, but in a way that fits the needs of the person. And finally, doing a safety plan. If there is a risk, we should try to engage a person in a safety plan that will give her the equip her to better respond and also give her the perception that she's better equipped. We should address where they should go that is safe if a risky situation comes up. If there are any dependents like children or elderly, do they take with them or do they stay? What can be done? What kind of transportation will be used? What they will take with them, clothes, money, food, documents, what is important, the phone, where they're going to put this in a way that it's easily accessible. But for example, if the perpetrator is from home, that we are not going to put the survivor at higher risk by being in a place that the perpetrator can find, where the perpetrator, the survivor can get some financial help or have access to money if he or she needs, and finally, who are the people that can help them who are the people that can help them in situation that they have to flee, they have to run to another place. Last question. When a survivor of sexual violence needs to be referred to specialized mental health care, obviously, whenever a survivor of sexual violence is identified, we should provide the option of referring. But what are the cases that are more severe and that need for sure specialized mental health care? How do we identify them? And again, ladies, I count on you.
Suicidal ideologies.
Mm-hmm. No more ideas?
Fistula, self-talking.
Mm-hmm.
If survivor present history of mental illness when they are not able to express themselves.
Okay.
Teenage pregnancy complications, insomnia.
Okay.
Self-harm events or ideology, the sign of severe depression after case assessment, when he is becoming suicidal.
Okay.
So about suicide, harming others or herself.
So suicide is obviously a big flag, no? When there is suicidal thoughts or attempts. What we usually say is that there are basically two big dimensions of needs to identify when we want to refer to specialized mental health care. One is functionality. So, is the person able to get out of bed? Is the person able to do their daily routine of taking care of the house, of going to work, of going to school, or not? If not, probably they need a referral. And then severe symptoms, suicide, then suicide attempts, yes. And you have to ask, don't be afraid of putting thoughts on someone's minds. No one puts thoughts like suicide, but it's really important that we are able to speak about suicide with people. Psychotic symptoms, so people that feel completely disorganized, that feel a bit disconnected, that are speaking alone, or they are speaking in a way that no one really understands or does not make sense. When there is a very extreme isolation, when the person cannot sleep for quite a while, or is not eating, or have big disturbances in their appetite or their diet for a while, when there is a lot of sadness, a lot of guilt, a lot of irritability, when there are many medical complaints that are not medically explained, sometimes when the person seems completely numb, when if he or she feels like she feels nothing, and this obviously is not normal after a situation of sexual violence, and excessive consumption of alcohol or other drugs. So all of this is all that can be done by non-mental health professionals when they are obviously properly trained and when they are supervised. What, for example, us in MSF, how is our package of care inside the MHPSS package, inside of done by the MHPSS teams? At the level 1 of the pyramid, I guess you all know more or less the pyramid of MHPSS care. We would have, on the basic needs and security, we would have our project coordinator, our field coordinator, doing a lot of advocacy, for example, with camp management or with protection organizations, to try to see if we can create more protective and safe spaces in the environment. We have, for example, our social workers working a lot on developing referral systems to internal referrals for medical care, or external referrals to other protection, legal, social care, whatever makes sense. At the second level, we would have our health promoters or our community health workers or community mental health workers providing PFA. And I know that for some organizations, they consider PFA at level 3, but for MSF, we consider at level 2. We also want to do general sessions on mental health, psychoeducation, explaining what is mental health, why people are more subject to mental health issues in that context, and what they can do to deal with that, and if it's still difficult, how to get to mental health. And like a year and a half ago, we started having psychoeducation, so awareness sessions on general violence, where we speak about the different forms of violence, including sexual violence, but not just. And here the idea is not for people to share, but it's for people to get more aware what to do when dealing with violence, and eventually to get some help if they need help. At the third level of the pyramid of care in MSF, we have now also a protocol for joint assessments. We'll have our counselors, our mental health counselors, our medical staff, and our social care staff providing, in some places, this is not implemented everywhere, joint assessments. So doing the first consultation all together to avoid re-traumatization of the person, to repeat the same story over and over again. But this obviously is also something that it's up for the person to decide if he or she wants to do it or not. The other idea, it's something that we also started like a year and a half ago. We start having psychosocial group programs where we address some skills that evidence and literature is saying that are absolutely essential in the recovery of people that have been through violence and through sexual violence. It's like programs of 3 to 5 sessions. They are modular. They are to be done by non-specialized professionals. And we have one program on general violence. We have another program on GBV, and we have another program on IPV, on interpartner violence. We are also introducing something that probably many of your organizations already do, the community spaces or safe spaces or child-friendly spaces. It was not something that MSF usually would do because it's not connected with clinical care, but we understood that we needed to create these non-clinical spaces for people to be more proximal to us, to have PSS care, but also to have social activities, to have respite care, to have recreational activities where they can rest, they can have a break, and eventually they can disclose events of violence and sexual violence and request help. And we train our colleagues on psychosocial care for survivors of sexual violence, colleagues that are not MHPSS. Finally, at the fourth level, we have the specialized care that is provided by our psychologists usually. And we do joint consultations with medical care and with social care for the first consultation for the assessment. And then we would provide individual care, group, and psychological support. I think below, I also forgot to say that we provide group counseling, individual counseling, and family counseling. Sorry. And we would have always also psychiatric care provided by a psychiatrist or a doctor trained on MHGAP. Last slide. For you to know, probably some of our organizations are also already working on this. And if not, I think it can be an inspiration. Something that we are working now is trying to have an algorithm, like a way of identifying survivors of violence, not just sexual violence, in our clinical facilities. So the idea is that anyone that is in a waiting area or in a consultation, the professionals around, not just doctors or nurses or mental health professionals, are able to identify key signs of violence and are able to refer to mental health care or to medical care. This is something that we are finalizing. It's not yet implemented. The other idea is to have all our staff trained on trauma-informed care. We are calling this workshop supportive care relationships. And the idea is to have everyone from guards, cooks, medical staff, mental health, social care, and managers trained on trauma-informed care. And finally, because we want to try to identify survivors of violence and sexual violence from the early beginning of our response in a place, we are finalizing also a package of qualitative assessments for mental health and sexual violence that is driven both to adults and children. And halas. And I'm already on top of my time. I hope we still have time for some questions if something comes up.
Thanks, Anna. We did have quite an active chat today. And maybe I think we are on the hour, but I will take this opportunity because a lot of the questions were really about the distinction, I think, and maybe it wasn't coming out clearly, the distinction between PFA, psychological first aid, and then also the case management process. And so I think we need to be very clear that PFA, or psychological first aid, is not a process that is necessarily specific to GBV. We use it in all different contexts in emergencies, whether you're responding to a fire or it could be anything. We also use it and we modify it in some ways to use it if you are a non-specialized individual who has come in contact with a survivor or someone at risk. So PFA is really about being a decent individual and using some of our guiding principles of safety and respect. When we train humanitarians on PFA in reference to GBV, we really add the component of informed consent, particularly for the linking aspect of it. So we had so many questions in the chat about PFA. Is it specific to sexual violence? What can we do? What are the confines or the boundaries of PFA? There are limitations, and I'm going to turn over to you in just a minute, Anna. And Anna, I think, was quite clear that you can use PFA as an entry point to then link a survivor to someone who has the expertise to take that case further if the survivor agrees, right? This is where informed consent at all aspects throughout. And I think a lot of the elements, Anna, that you spoke about later on also speak a bit more about case management, which is more technical, and you need more training and supervision than you would for PFA. So Anna, maybe you could also, from the perspective of MSF, give us the distinction, because I know here at the GBV AOR, we've made a very big distinction between PFA, non-specialized, and then case management, which is very much specialized and professionalized in terms of how you would then treat a case. Because we also got into a lot of, would you then, refer a case? Would you start doing safety planning? And during the PFA process, if you're a non-specialized service or, just a humanitarian, you would not be engaged in safety planning because that would be over the limit of your remit. That was when we would want someone with more professional understanding of how we actually address cases of GBV for safety for both the survivor and the provider. So I'm going to turn it over to you, Anna. That one, I think, came out a lot of questions around PFA, and they weren't identifying case management, but I recognized that they weren't maybe seeing the distinction between PFA and a professional case manager per se, whether you're a nurse doing case management services, whether you're a psychologist doing case management services versus a kind of, non-specialist. You could be a water sanitation person. You could be the guard. Over to you, Anna.
Yeah, so PFA can be used by basically anyone, no? That has been trained and again supervised. And it's the first line intervention, again, when something just had happened. In case management, I would also see the relevance of when we speak with people, because it's like Jessica is saying, PFA, or when we speak about psychoeducation, validation, reassurance, is about proper communication with the survivor. So in your case management, and when you have, not when you are a guard or a cook or a driver that somehow gets in contact with the person, this would be profiles that would just provide PFA. But if you have already a protection profile, or you're a nurse, or you're a doctor, or you're a mental health professional, I would say that we can go to the next step of providing some psychoeducation on speaking about coping mechanisms, and speaking about family support, speaking about going back to a routine. But this obviously is a bigger conversation, and it's something that should be in a proper room, and we should have a proper space for that. Then when we identify in our case management platform that there are specific needs for mental health care, we refer, no? And usually, and in MSF, whenever we identify a survivor of sexual violence, we ask, even if we don't see severe symptoms, we ask if they want to be referred to specialized care or to mental health care. And then we define, according to the severity of the person, if it should be specialized care or non-specialized care. The idea is that the specialized care are usually more urgent, and we have to have teams and in the referral pathway to push for rapid response to that person. Was I clear?
Yep, I think so. Yeah. I'm going to take one more question, and this is from Deborah. And the question is about, we know that MSF is very clinically based, and she had a question about how do you approach a community-based perspective, knowing that, and someone else, and I love this person, also mentioned the social ecological model. And so we know that we cannot address GBV in isolation, just from one service perspective. So from an MSF perspective, how are you also looking at the community as a wider entity?
So at this point, we have our community engagement is bigger and bigger. It's something that we are trying to develop as much as possible. We don't have one strategy because it depends a lot on the context, on the physical structure and security, but also on culture of the population. How can we address sexual violence? So the recommendations that we give to the field at this point is ask people. start by asking your own staff, because they usually they are local staff and they understand very well the community and how we can address these very sensitive topics. And then try to have some focus group discussions and some interviews with key people in the community, and we try to structure the awareness about sexual violence and violence according to that. So I don't have an answer, because the answer is be proximal to your community, ask and see how it's relevant for them. The other idea is what I was telling in one of the last slides, that we are trying to be more proximal and less clinical, for example, with the inclusion in some places of safe spaces. And tomorrow, our team in Palestine, they are now working for a while with safe spaces. So this for us nowadays is absolutely essential to work better in community engagement and to start integrating this kind of spaces in the community, that we will be closer without being so clinical. Because it's true that MSF is very clinical, and this was a problem when identifying and developing this trusting relationship with the population. From a mental health professional's point of view, we are integrating now these PSS group programs that I was telling you. So we are having conversations about violence in general, and then we can have more specific conversations about GBV or IPV. We are also having conversations about stress management, about grief and loss. So we have group programs on all of these parenting skills. And what we are also putting in place is a strategy that has entry door programs like stress management or parenting skills, that we start by building this trusting relationship with the population. And with time, and after identifying people at high risk, or actually that have been assaulted or have been subject to other forms of sexual violence, that they can feel comfortable to come to us. What is also happening in these PSS group programs is, for example, in one place in Car, that after we ran one or two, we start having people knocking on our door saying, we know that you're doing this, we want to be part of it. So these PSS group programs have also a very positive side effect of being closer to the community and being able to develop this trust relationship with the community.
Great, thank you. And I think it's so important from a GBV, a coordination perspective. This is kind of our role as well, is to make sure that we do have a broad range of services and support systems for our survivors. And so many times we do that through our women friendly spaces, women safe spaces, depending on the context. And we've done some studies that have showed if you do have the community support components, you're more likely to have a survivor who's more willing to access services and then also complete services and to go on to recovery. So really, really excellent point, Anna. I see that we are past our hour. We had a very active chat today, which we really appreciated. Ryan, I appreciate your responses. You gave a lot of comprehensive responses to our participants today.
I'm still trying.
I know there were a lot of good ones and complex questions this time. And I could see that we had a lot of professional service providers on the line today, which was really exciting for us as well. I want to remind everyone that this is a three-part series. So tomorrow, which I think is going to be very exciting, we have some experts from the field who will be joining us from Palestine, who will actually show us all of these concepts in practice. So how does it work in practice? Which we had a lot of questions in the chat around that, where we had some specific incidences or characteristics that people asked about. And I think those questions will be answered more fully tomorrow when we look at the practical application of what was discussed yesterday and then also today. So remember to join us tomorrow for the last session of our three-part series. It will be at the same time, 2:30 East Africa time, and you will be able to use the same link, But as similar to today, we will send out reminders so that there's no way that you cannot join us tomorrow to be able to listen and learn from some experts who are doing this amazing work in very, very complex environments. So I want to thank so much Anna and then also Rand for helping in the chat for these great presentations today. I also want to remind everyone, since, yeah, I see the slides, we do not distribute the slides because we want to make sure that you are learning this information within the context of the presentation. So we will not be disseminating the slides, but you can access a recording of this webinar on our YouTube channel. All you need to do is go onto YouTube and then search for GBV AOR, and then you can find a recording of this webinar, probably by tomorrow, I'm guessing, and all previous webinars and learning events that we have hosted over the past 7 years on our YouTube channel. So please make sure it's a great reference or resource for all service providers. We have tons of videos and technical videos online on our YouTube channel. So we will not be giving out the PowerPoint presentation because we want to make sure the information is contextualized, just like Anna did today. You can find it on our YouTube channel. Whew. All right. Thank you, everyone, for joining us today. Thank you so much to MSF, to Anna and to Ren. We look forward to seeing everyone back tomorrow at 2:30 East Africa time using the same link, but we will send out reminders. Thanks, everyone, for joining us. We look forward to seeing you tomorrow for the last event of the Regional GBV Working Group for East and Southern Africa's 16 Days Activism campaign. And remember that healthcare is a human right, along with mental health care as well. And we're here to promote that from here in East and Southern Africa, but also around the world. So thanks everybody for joining, and I hope you have a great afternoon.
Bye. Thank you.
Thank you.
Bye.
Thank you all.
Thank you.